Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. This lecture will be about chest, a bullet in the chest. What are the measures or the major diagnosis or the cases that presented in bases? You have to look at the fingers to look for tar staining and clubbing. Tar staining and clubbing. It will give you idea about what you are looking for. Clubbing maybe fibrosis, maybe bronchiectasis. Tar staining maybe obstructive lung disease. You would look for signs of hyperinflation. If you find signs of hyperinflation, it would be obstructive with or without restrictive element. You should look for the trachea, the position of the trachea, if it's shifted or not, and the auscultation, air entry and crepitation. Thus, the vocal resonance and the chest expansion and chest percussion would not have this beneficial elements in the exam, so just run it to save your time. What are the causes? What are the investigations? The examiner will ask you what are the investigations you would do for your patient. You should say it loud. Basic investigation, complete blood picture to look for anemia and leukocytosis, erythrocyte, sedimentation rate, and CRP, C-reactive protein to look for any signs of infection, urea and electrolyte to look for any affection of the kidneys, sputum culture and sensitivity, and for acid-fast bacilli. You will do EPG if the patient in respiratory failure to look for type 2 respiratory failure in chronic obstructive pulmonary disease and type 1 respiratory failure in restrictive pattern. And we will do pulmonary function test in which forced expiratory volume in 1 second on forced vital capacity will be more than 80 in restrictive pattern and will be less than 80 in obstructive pattern. The scans, your scans will be X-ray to look for the sign of the disease itself and for any other complication, high resolution CT scan to look for fibrosis and any mass lesion or abscess, MRI, the same, bronchoalveolar lavage and lung biopsy if indicated. The second question, in cases of fibrosis, if you find a clubbing in his fingers and fine crepitation, maybe basal, maybe apical, you should say what exactly you found the fibrosis. Is it on the right, on the left? Is it basal or apical? Is it on unilateral or bilateral? If the fibrosis, the fine respiratory crepitation that not change with cough apical, you would say the cases would be ankylosing psoriasis, cold or longer hands, or perilosis, radiation, extrinsic allergic alveolitis, aspergillosis and sarcoidosis and TB, breast collapse. Cool, longer hands, ankylosing and psoriasis. You may look carefully for ankylosing and psoriasis in the exam, and you may say extrinsic allergic alveolitis, aspergillosis, sarcoidosis, and TB. If it's basal, if you find basal fibrosis, you may put it in Riyadh, rheumatological and idiopathic asbestosis and drugs. Rheumatological and idiopathic interstitial fibrosis, asbestosis and drugs like methotrexate and nitrofurantoin and amiodarone. What are the causes of clubbing? What are the causes of clubbing? Interstitial lung disease, cancer, bronchiectasis, cystic fibrosis, lung abscess, and TB. What are the complications of fibrosis? Pulmonary hypertension, pulmonary congestion, cor pulmonale, chest infection, and lung cancer. So the next question, what is the management of interstitial lung disease? Like any management in any scenarios, you would say non-pharmacological and pharmacological and surgical. Non-pharmacological would be patient education and counseling about his disease. vaccination against pneumococcal and influenza and the seasonal influenza, stop smoking, of course, and the pulmonary rehabilitation program. What is a pulmonary rehabilitation program? It is psychological and social and nutritional support with physiotherapy for the patient. What is the pharmacological treatment in cases of interstitial fibrosis? Steroid and steroid-sparing agents, antifibrotic agents that might help in idiopathic interstitial lung fibrosis, pirfenidone, or long-term oxygen therapy. The last, surgical with lung transplant. What is the management of chronic obstructive pulmonary disease? If you find a patient with chronic obstructive pulmonary disease with or without fibrosis, but there is an element of obstructive pattern, chronic obstructive pulmonary disease, you would say non-pharmacological. Number one, stop smoking, patient education and counseling, vaccination against pneumococcal H influenza and seasonal influenza, pulmonary rehabilitation program, which just have been mentioned. Pharmacological, bronchodilator with short-acting beta agonist and according to FEV1 or forced expiratory volume in 1 second. If it's more than 50, you would give short-acting beta agonist with long-acting beta agonist or was with long antimuscarinic agonist. If FEV1 between 30 and 50, LABA or LAMA plus inhaler, LABA or LAMA plus inhaler corticosteroids. If FEV1 less than 30, you may use LABA plus LAMA plus inhaler corticosteroid. In cases of exacerbation of obstructive pulmonary disease, you may use oxygen 24%, systemic steroids, mucolytics, antibiotics, and there is indication for long-term oxygen therapy. What is the surgical option in chronic obstructive pulmonary disease? Lobectomy, endobronchial valve replacement, lung reduction, and transplant. What is the long-term oxygen therapy indicated? What is the long-term oxygen therapy? LTOT. VO2 measured 3 weeks apart and the patient is stable and non-smoker. The patient must stop smoking and is stable, and the measures, it would be 2 measures 3 weeks apart. It would be supply of oxygen 2 to 4 liters for 15 to 20 hours per day. Indication if VO2 less than 7.3 or VO2 7.3 to 8 with pulmonary hypertension, core pulmonale, secondary polycythemia, and nocturnal hypoxemia. The second question is the differential diagnosis of dullness on percussion. If you find on percussion there is dullness, it might be pleural effusion or pleural thickening or consolidation, might be collapse, lobectomy, or raised hemidiaphragm. Differential diagnosis on percussion may be pleural effusion or pleural thickening, consolidation, collapse, lobectomy, or raised hemidiaphragm. What are the causes of bronchiectasis? Bronchiectasis, you would find clubbing on the fingers, you would find and in respiratory crepitation that change with coughing, Idiopathic infection like childhood measles or pertussis, immune deficiency in HIV or immune hyperacting like aspergillosis, obstruction by foreign body or by mucus, congenital like cystic fibrosis, immotile cilia, Cartagena syndrome, and yellow nail syndrome. What are the indications for lobectomy or pneumonectomy, trauma, tumor, TB, and bronchiectasis? What are the indications for lobectomy or pneumonectomy, trauma, tumor, TB, and bronchiectasis? That is the gist wallet, and thank you. Wassalamu alaikum wa rahmatullahi wa barakatuh.